information management, and this program does very well to do that. We also have tumor boards that are live interactive with Brazil. We link with the Brazil Society for Cancer, and we broadcast these interactive lectures across Brazil. We just were awarded by the American Academy of Dermatology the award for innovative continuing medical education. We have monthly, global, international dermatology lectures. One of our lecturers speaks to groups who are in Colombia, Brazil, Panama. We network with networks within countries. So the Mexican government has a telemedicine network, and Brazil as well, and we link with them to be able to give these lectures, and we've gotten excellent feedback. The first one, we had 176 participants, and it went very well. In Haiti, we have several projects. One we are helping to facilitate is by adding video conferencing capability. We have neurosurgeons who go down twice a year on a mission from and Miami Children's, and they do shunt procedures for children with hydrocephalus. What we are now going to be able to do is offer them the ability to do pre-screening for these patients before they get down, enabling them to do more surgery during the time they're there, and also for the first time for them to have post-op care so they can give follow-up for those surgical patients. We also have a residency program, family medicine in capitation, and we will now be able to have interactive lectures and education for them. Research and development is important, and we are doing a fair amount of it, funded a lot through Congress and the DoD. Bascom Palmer received a $2 million congressional allocation for research in innovations in ocular health. And what I'm showing you here is optical coherence tomography, and what we're doing at Bascom Palmer is developing the next level of OCT so that it can be managed by people who are not ophthalmologists, so that in the future, in theater, a med tech can do a scan, be able to determine, does this person have an injury that needs to be evacuated or not. We also have a TATRIC grant, which is the Telemedicine and Technology Research Center out of the DoD, for testing the validation of remote audiology. Can you really test someone's hearing remotely? And we're working with Kent State, Triple Army Medical Center, and we'll be doing a round robin of patients who are getting hearing tests here, then in Kent State, and then Tripler, validating that for normal hearing and abnormal hearing patients, we can do that effectively and correctly. Ryder Trauma Center has a DoD grant, and there we're using a robot to assist in resuscitation rounds when they come into the Ryder bays. There's a grant we received to give educational programs in Landstuhl. I don't know if you are aware, but Ryder trains for 2 weeks the forward surgical teams that get deployed to Iraq and Afghanistan. Those folks, when they go into theater and into Landstuhl, they don't get follow-up in terms of more education. And so what we have initiated is a lecture series with those military personnel so they can keep follow-up, and we will be doing it with appropriate feedback from them so that it's what they need when they're there. But what are the emerging opportunities in this field? There are many. One is technology and product opportunities. Devices, software, and collaborative tools. And I'm just going to take a couple minutes and tell you, because we do have industry and entrepreneurs here. Devices we're using now in telemedicine use analog technology, standard definition, and they're all proprietary. What we really need to diffuse telemedicine is interoperability. We need a plug-and-play, simple device. We need these devices to be wireless so that they're not tethered to our equipment and we're in a tangle of wires when we do our exams. We want devices that can do video but then can capture still images and also send video clips so that we can have a really robust amount of information. When images are taken, we need to have patient identification and date embedded in those studies so they can be identified with the patient. The last thing I want to do is diagnose a melanoma and have it the wrong patient. Not what I want to do. Additionally, with traditional imaging technology. It's large. You need a facility that's an MRI, ultrasound. What would be ideal would be small, portable devices, little miniaturizations of our traditional imaging, so that it can be in doctor's offices, in rural clinics, so that we don't have to have the additional expense, inconvenience for the patient in a large facility where the expense is more, and the information results would be more prompt. For software, you know, we all have PDAs. It would be lovely, don't you think, if our traditional clinical appointments and our telehealth appointments could just be beamed into our PDAs? Be real nice. But additionally, it'd be lovely if, in addition to telling me I have an appointment, I should be there, if I had a telehealth appointment, it would be lovely if the telehealth center and the IT tech who's going to help facilitate that would get the information at the same time. We'd all be on the same page. The electronic medical record, which is coming, and it's slow, we've been talking about that. What we really need for telehealth care is to make it multimedia enabled so that we can have audio clips, video clips of studies, and also video clips of significant parts of the physical exam. So that can be part of the record, because that's the critical part that will be able to move healthcare forward. In terms of collaborative tools, while there are whiteboards and there are virtual communities that are in existence and they're being used, they're also really expensive to use. It's expensive. We just implemented SharePoint. It's expensive to implement, to maintain. It's also not intuitive. It takes a lot of training, and it's time-consuming. Last thing I would just say is that if we could have EMRs that would, the collaborative tools, so that we can share EMRs among physicians, so if we have a tumor board, we can all be looking at the same record, or we can all be looking at the same CT. That would make patient care much better. So really, the model we want to emulate is the most commonly device used in healthcare today. So I'll just ask you all, what do you think that most commonly used healthcare devices? Pardon? Cell phone, maybe? I would venture to say that it's the fax. And why is it the fax? Because it's ubiquitous, it's all over, it's in your home, it's in the office, it's in the nursing home. It's easy to use. You don't think so? I think so. It's reliable, and it's secure. It's HIPAA compliant. It's 1980, but it works, and it's easy. The reason I'm saying it is that what we're using as our standard medical record is paper right now. So for that reason, it's the most common use. The reason I mention it is that the ease, the ubiquitousness nature of it, that's what we need for these tools, these devices, in order to be able to really catalyze the change toward telehealth. What are the research opportunities? Certainly innovative technology, some of the device and software ideas that I presented. Clinical applications to expand them. Tom Brewer, Tom, you want to raise your hand? He's our operations manager from, just joined us from Montana. He had a sleep lab where he was able to monitor patients remotely. Well, that's an interesting application. Scott Simmons, if you raise your hand, he's our director of telemedicine. They were doing EEGs remotely. That's a novel but very useful kind of application. We need to study economics so we can really document well that this is effective, and if it isn't cost-effective in all specialties or for all applications, which ones there are, because based on that, it's possible that Florida could become a state, like 5 others that are in the country, where it is mandated by law that all insurance companies pay for health care and a face-to-face evaluation is not required. So if we were the 6th state, then it would be an insurance company would have to pay for a telehealth consultation, and no arguments. Right now, they're not paying. Communication between patient and physician is different now with telehealth. It'd be important to study what are those factors, what is the ease and the comfort for patients. Are there certain ones where it wouldn't be appropriate? And